For many pulmonology practice owners, keeping medical billing in-house feels like maintaining control. You can walk down the hall and talk directly to your team. But looking closely at the operational data reveals a different reality. Managing billing in-house is often a practice's most expensive and fragile liability. The primary mechanism driving this fragility is a structural one: the rapidly rising rate of claim denials across the entire U.S. healthcare system. Kodiak Solutions analyzed data from over 300,000 physicians, showing a steady climb in initial claim denial rates, reaching 11.81% in 2024. At a clinic level, roughly 1 in 8 medical claims is rejected on the first pass. Pulmonology is highly exposed to this trend. Patient treatment routinely requires complex diagnostic procedures, such as spirometry, polysomnography, and bronchoscopy. Each of these procedures carries specific CPT codes and intricate modifier requirements. A slight mismatch with a payer's unique documentation rules immediately triggers an automatic rejection. Premier Inc. data shows private payers denying 15% of claims, Medicare Advantage at 15.7%, and Medicaid reaching 16.7%. According to MD Audit, the average dollar value tied to these denied outpatient claims recently rose by 14%. The most damaging aspect of this process occurs after the initial denial. A significant portion of these denied claims are never resubmitted. The temporary hold becomes a permanent, unrecoverable loss of revenue. Relying on a small, isolated in-house team to fight a mathematically increasing systemic denial trend places a practice at a structural disadvantage. It quietly drains the bottom line. Retroactive claim denials are only one side of the equation. Prior authorization has evolved from a standard administrative task into a severe operational bottleneck. High-value pulmonology treatments, specifically sleep apnea devices, advanced imaging, and inhaled biologics, consistently require pre-approval from insurance carriers. The American Medical Association's 2024 survey quantified this workload. Staff complete an average of 39 prior authorization requests per physician per week. Processing those requests consumes an average of 13 hours of physician and staff time every single week. The volume is so severe that 40% of practices now employ staff dedicated exclusively to handling prior authorizations. This continuous administrative pressure exacts a heavy toll on the workforce. 89% of physicians report prior authorizations as a primary contributor to exhaustion and burnout. The delay extends directly to clinical outcomes. 94% of physicians note that patients have delayed or entirely abandoned necessary care due to these administrative holdups. Payer portals artificially multiply this administrative workload. They apply entirely different authorization rules for the exact same procedure code, depending entirely on the patient's specific insurance plan. Prior authorization acts as a direct threat to patient care and serves as a primary driver of the overhead costs currently overwhelming small administrative teams. Maintaining the staff required to fight these denials and secure authorizations introduces another operational reality. Base salary is only a fraction of the actual cost to the practice. The Bureau of Labor Statistics places the median wage for a medical record specialist at $50,250. Securing an AAPC certified coder requires a premium, pushing that baseline to $58,000. This stacked chart breaks down the fully loaded cost of a full-time equivalent. Adding benefits, payroll taxes, training, and the cost of errors pushes the true annual expense to between $55,000 and $75,000. That financial calculation relies on a crucial assumption: that the employee actually stays with the practice. According to the MGMA Data Dive report, business operations support staff saw a massive 33.3% turnover rate in 2022.
Turnover carries a strict financial penalty. Recruiting a replacement and absorbing the lost productivity costs practices between $25,000 and $30,000 per departure. The operational damage cascades quickly. A new hire starts from scratch. Productivity drops, unworked claims accumulate, and days in accounts receivable stretch out. Training new staff on complex, specialty-specific knowledge, like pulmonology modifiers and sleep study billing, takes months of supervised effort. That highly specific training investment instantly vanishes the moment a staff member accepts a higher-paying remote role at a larger health system. This in-house model forces practices to constantly rebuild their administrative foundation. When a third of the team departs annually, the resulting training lag and productivity drops make reaching the 95% first-pass resolution benchmark an elusive goal. A growing number of pulmonology practices are adopting an alternative model, completely outsourcing the billing function to a specialty-trained team. This is a system of embedded outsourcing. AAPC and AHIMA credentialed specialists function as a dedicated extension of the practice, working within existing workflows, maintaining continuity. This approach creates operational continuity. The exact same dedicated specialist handles the queue daily, deeply learning the practice's specific payer mix and patient population. The technical integration is direct. The outsourced team works natively inside the practice's existing EMR, whether that platform is Epic, Athena, or eClinicalWorks. There are zero screen share delays. It is a direct, secure connection established rapidly within a 14-day go-live window. The entire operation runs under strict SOC 2 Type 2, ISO 27001, and HITRACE-aligned workflows, secured by a Day 1 business associate agreement. To support these human specialists, the workflow integrates artificial intelligence, providing an infrastructure that small in-house teams simply cannot replicate. In this flow diagram, smart routing automatically prioritizes claims by urgency, while predictive workload management prevents queues from backing up. An automated audit system performs point-of-submission claim scrubbing. It scans and flags potential coding errors before the claim is sent to the payer. Combining healthcare-trained human specialists with this layer of AI technology directly targets the root cause of denials, driving error rates below 1%. The strategic value of this transition becomes clear when comparing the financial calculus of the two operational models side by side. As established, the fully loaded cost of a single in-house billing employee requires $55,000 to $75,000 annually when factoring in benefits and overhead. Staffingly operates on a predictable, fixed-rate pricing model, starting at $399 per week per seat. This comparison shows the disparity. Annually, the outsourced model costs roughly $20,748. At volume pricing, it drops to $18,148 per seat. This arbitrage saves your practice between $34,000 and $56,000 per year, compared to a fully loaded in-house hire. Practices consistently report measurable positive returns on this investment within 60 days of their initial 14-day integration. The model relies on total visibility. Weekly KPI dashboards give practice owners direct oversight of throughput, accuracy, and turnaround metrics. The integration is designed to be frictionless. Practices maintain the flexibility to scale up, scale down, or cancel with 30 days' notice, shifting to a month-to-month agreement after an initial pilot. Shifting to this model ends the cycle of rebuilding administrative teams from scratch, allowing a practice to protect more of its earned revenue while reclaiming significant staff bandwidth for patient-facing tasks. Book a strategy call today for a 30-day free trial. Go live in 48 to 72 hours. Visit staffingly.com/demo or call 800-489-5877.